It's a beautiful day in the Detroit area, or should I say a beautiful day in Region 10. Sun is shining. We've had a lot of rain. And I don't know about yours, but my flowers are very happy. They are very happy and very beautiful. The grass is very green. It all makes for a beautiful day. And welcome to the SEMPQIC Coalition meeting. We have an action-packed agenda, lots of good information, bringing you up to date on some very important things that's going on, opportunity for you to maybe chat with each other. And so we really want to get started. It's around 1 o'clock, a few minutes after 1. So again, I'm Vern Anthony, one of the leaders of SEMPQIC, Southeast Michigan Perinatal Quality Improvement Coalition, and welcome. The team members are present and you'll be hearing from them, most of them throughout this afternoon. Dr. Iris Taylor, Alethea Carr, Lisa Braddix, Karen Schrock, Dana Harvey, that's our new communications consultant. You'll be hearing from her later. Andrell Sturdivant, Jennifer Torres from MPHI, who does our evaluations with us. And of course, Devin, that keeps us all connected. So we all welcome you. Our first agenda item is the COVID vaccine update. Dawn Schonefeld is going to be presenting, but Dawn is also a very active member of our team and extremely helpful with all of our goals and objectives and bringing a lot of state support. So you'll be hearing from Dawn, and following Dawn, you'll be hearing from Dr. Iris Taylor. Again, I mentioned Iris is one of our co-leads, but Iris is also managing the City of Detroit vaccine effort. So again, welcome everybody. Sign in the chat if you haven't already. And Dawn, handing it to you.
Thank you so much, Vern, and welcome everyone. I'm going to take a few minutes and give a brief COVID update, including a vaccine update, and then I'm going to turn it over to Dr. Taylor for some real on-the-ground information. Next slide, please. So hopefully you're all aware that as of midnight or 12:01 today, the rescission of emergency orders took effect, and there was also a press release that was held today as well, so I'd encourage you to view that. Overarching, everything's listed here that was rescinded, but I think most importantly to everyone are the orders regarding gathering limits and face mask orders. And I want to point out, though, that even though those items have been lifted, people should continue to do what they feel is safest. Next slide, please. These are our latest COVID-19 update numbers for the state of Michigan. And I thought it was really important to celebrate where we're at. Things are definitely in a much improved state, but then also remind everyone that there are still active COVID cases and still deaths that are occurring as a result of COVID-19. So you can again see the numbers on the right. And then also you'll see that I'm sure our EPI team at the state and state lab is very relieved for a bit of a breather at this point. We'll no longer be reporting data on the weekends. So that will give them a bit of time for families. Next slide, please. This is the COVID-19 vaccine dashboard for the state of Michigan. And I want to point out that this tracks the first dose. You can see the specifics, and I'll show those in the subsequent slides for complete doses, but we're tracking the first dose as we move forward to reaching President Biden and Vice President Harris's goal of 70% of Americans having at least one COVID-19 vaccine. In Michigan, as of the 18th, which was the latest date that the dashboard was updated as of yesterday evening when I created the slides, we're at 60.8 in Michigan. Next slide, please. I shared some of this information before, but I want to give you a brief update on where Region 10 stands. So this is for the city of Detroit, and right now we're looking at completion numbers. So how many individuals are fully vaccinated in the various areas of Region 10. And so for the city of Detroit, we're at 30.3% of all city residents being fully vaccinated. Next slide. This slide is showing us for, you can see up here, the Wayne County Health Department. So all the areas in blue and the white is the city. So this is the surrounding areas. And right now, Wayne County Health Department is reporting 56.7% of the citizens are completely vaccinated. Next slide, please. And this is Macomb County. And Macomb County is 50.7%. Next slide. And in Oakland, we're at 60.7, which is right in par with the overall state vaccination percentage. Next slide. And the next slide, please. Now I'm going to share some updates. As you all know, Michigan is part of the CDC COVID-19 pregnancy and newborn surveillance project. So we've been part of this project since the onset of COVID-19 in the state. And our EPI team, again, works very closely with Vital Records and the state lab to identify moms that were pregnant in the calendar year 2020, who also had a positive COVID-19 test, as well as their infants, once their infants are born. And we're following for impact on a variety of pregnancy outcomes, including infant mortality, preterm birth, maternal mortality, ICU admissions for both mom and baby. And then, as I mentioned a minute ago, COVID infections in infants of the babies that were born during this time. Next slide, please. So to date, and the date would be May 24th, there have been a total of 1,379 confirmed COVID-19 diagnoses during pregnancy in 2020. So during moms who were pregnant in the year 2020. And as we know, some of those moms may not have had their babies yet. For example, if they just became pregnant in November, December of the end of last year. The total number of women with confirmed COVID-19 diagnosis during pregnancy who have a pregnancy outcome, which means we know the results of their baby's been born, 1,033 cases. And then this is broken down by demographic. And at this point, I know last time we had asked if we could see the data broken down by rate, because obviously when you're looking at percentages here, you're not able to see the disparities. At this point in time, we don't have rate. We're hoping to have it very soon. Next slide, please. So the percent of moms in our cohort so far that were symptomatic, so I think this is really important, was 79.3. So I think that's interesting, given that we know that COVID can be asymptomatic, but the moms who were pregnant, the majority had symptoms of COVID. Of the babies that have been born, over 1,000 babies, 12.6% were documented as being born preterm, which is higher than our state percentage. Of all of the babies born, 10.5% were admitted to the NICU. So they could have been admitted to the NICU for medical reasons for the baby. In the early time of COVID, I had shared that sometimes the babies were admitted to the NICU for observation because mom was actively being treated for COVID. The percentages of the infants, thankfully, that tested positive to COVID-19 is less than 1%. And you'll know that there's been quite a bit of research published about the fact that babies can get antibodies from their mother when she's positive during COVID-19. There are several physicians on the call today, so in the meeting today, so please also chime in as well. The percent of infants who were ever breastfed is almost 48%. And I think that's really good too. When you consider, I mean, definitely we'd want it to be higher, but when you consider at times in the very beginning of the pandemic, moms and babies were separated. So that definitely impacted, the ability to breastfeed. So this number again is low, but I think it's still good and hopefully will rise as time goes on. Next slide, please. So here's my contact information. As always, feel free to reach out directly to me by texting or calling on my work cell phone or sending an email. And with that, I'm going to turn it over to Iris, who's on the ground, real public health information.
Thank you, Dawn. As we look at specifically in the city of Detroit, and obviously the disparity in the numbers between the amount of the individuals who are vaccinated in the city of Detroit compared to the rest of Region 10, that's only to compare to the state. The slide you have before you breaks down as of June the 16th, individuals who have been vaccinated at least by one dose in the city of Detroit by age. Starting again with the Pfizer, that we're giving at age 12 to 15 through plus 75. You'll see that our largest percentage of those who have engaged in the ages 65 to 74. Next slide. If we break this down by ethnicity, you see to 51% are Black or African American. That 28% is that because in our database, we don't require you to complete the section that identifies ethnicity or race. So there's 28%, a large number that's listed as being unknown. The next slide. Specifically for the areas of Detroit, we look at it in terms of districts. The city of Detroit is divided up into 7 districts. So we look at those areas that at least one dose, this is the percentage of that population that has been vaccinated. And examples of some of the zip codes that you see represented, for example, in District 1, you're looking at 48219 or 48223. Or parts of 48227. Some of the zip codes cross over in districts. District 2, an example would be 48235. District 3 would be 48235. District 3, whether it would be 48234. And District 4 would be 2415 or 48205. District 5, an example of that is 48214, which is downtown, 48206 and 48207, 48202. And in District 6, we're looking at 48216, 01, 48226 as examples. And in District 7, you would be looking at 48238 or 48237. So those are examples of some of the zip codes that are represented. When you go to fully vaccinated, go to the next slide, please. The percentages drop just a little bit, but that gives you an idea of the representation in each district being approximately the same as we move forward. So what are we doing to try to close that gap? We have outreaches that we have been engaging in since mid-February. And in that effort, we have conducted over 1,300 vaccination clinics throughout the city of Detroit. And as you look at some of the categories listed, there are fixed locations, Monday through Friday. There are locations that occur only on Saturday. And then there are locations that we call pop-ups that are by specific categories, such as a senior citizen pavilion or a specific zip code or area. In addition to pop-ups, we also have special events and the mobile unit. So all the categories you see listed there. But our desire is to have equitable access to vaccines, and so that individuals who wish to have a vaccination has the ability to get it. And the reason I put it on the map is so that you can sort of see that strategically we have designed it so that we are going not only to areas that were previously identified as hotspots, but also just to see to it that geographically across all 7 districts that we are providing some level of access to the vaccinations. Go to the next slide, please. So what are we doing today? Our most recent strategic effort is beginning with home visiting strategy program. And that particular strategy is saying that if you don't want to come out to any of our multitude of clinics that are available, that we will provide a home visit. And so in partnership with the Michigan Department of Health and Human Services and Wayne State University and DAAA, with that partnership, we are providing home visits. Sadly to say that we've not had a lot of takers so far, but we're going to continue to pursue in that effort. But you'll see beginning to advertise a number where people can call in or make a self-appointment if they go online. And we will be calling those referrals that we get from individuals to saying that we will come to your home and vaccinate you and your friends and family. If you let us know the number, you could have a vaccine home party if you desire to do so. We also have 7 sites that are permanently located, including a drive-through in the neighborhood on Grand River at Straight Gate Church, as well as downtown at TCF. We have weekend community sites on the weekend at churches, and we will continue to do our vaccination pop-ups and special events, including our mobile unit that's out 6 days a week. So that represents the strategies that we're engaged in to close the gap that overall, while we're at 30-something% for fully vaccinated and a little bit more than that for 1 dose as of June the 16th, we're a long way from community immunity, which is what our desire is.
Iris, how can this group help?
This group can help in a couple of ways. In our current strategy for home visiting, anyone who has a list of individuals that you think may be positively respond to a home visit call, if you are willing to provide their name and phone numbers, we will call them to make appointments for them. If you're willing to broker by contacting them yourself to get appointments and then transfer that information, that would also be acceptable and very helpful. If you have other strategies that you think that would be positive for the population of the city of Detroit, we are welcoming any ideas of strategies that we could partner to implement. We're willing to do that as well.
Iris, do you have, this is Gaylada, do you have a flyer or anything that we can post to our website?
Yes, I can forward that information to you. We have flyers that describe where all of our locations are at any given point in time, as well as a phone number for those who are interested in home visiting.
Great, good, thank you.
I haven't noticed somebody else is asking a question. Who was?
This is Teresa Holtrop. I was just wondering, are any of the primary care practices handing out COVID vaccination?
Yes, there are several primary care practices within the city of Detroit. There are urgent care facilities within the city of Detroit that we've also partnered with and that we provide the vaccines for them. And we have pharmacists that we have partnered with that we're providing the vaccine for the drugstore, for that particular private pharmacy, and not just CVS's and the Walgreens. We've also partnered with CVS and Walgreens in some special events in terms of increasing the accessibility across the geographics of the city of Detroit.
Any pediatric practices?
No, not excessively. We've had a few primary private pediatricians who have inquired, and we're partnering with them, but not as a mass effort. As you know, the Pfizer just recently became available for ages, and we're not yet able to vaccinate 12 and below.
One more question. Is there any planned mass vaccination for schools coming over the summer?
We have clinics scheduled with DPSCD and some of the charter schools already for the summer. DPSCD in particular, over the summer, they have these educational learning hubs that are available. And we will be providing Pfizer for 3 weeks in each of those hub sites across the city. They are geographically located throughout the area for DPSCD. And there are also some scheduled within some of the charter school districts as well.
Okay, any other quick questions? If not, if you have any, put them in the chat. We'll move on. I just want to stress again, and speaking to the choir here, the importance of vaccinations for COVID. There's this new variant, as you all know, that's out there that's probably going to hit hard. People that are not vaccinated. We appreciate the governor and opening Michigan back up, but it's not over till it's over. And we have a long way to go with vaccines. So thanks, Iris and Dawn. And again, if you have any thoughts or, that you think might help, everybody's open to continue to improve. Okay, moving on. We're gonna have now Lisa Braddix share with you an overview of our Michigan Infant Health Equity Improvement Plan. Guys, remember this Bible, this book? Well, we meaning SEMPQIC, evaluate our progress in terms of the overall state goals, our progress in Region 10 annually. And we just completed our scan. Lisa, you want to tell us what we found and how we're going to use the information?
Yes, sure. So I will do my very best to cover all of the data in the next few minutes. I know that I've got a time clock on me so that we can get to the rest of the agenda. But this certainly, if you say we're with us more than a year ago, this is the second time that you have experienced this environmental scan survey, and it serves to help us determine what priority areas you all are focusing on, what's going on in our region in terms of the recommended strategies that are in the improvement plan and who is doing what, and what we as a coalition need to focus our efforts on based on what everyone is doing currently and what you all are looking to do in the future. So this is just an overview of the responses. We received a total of 34 responses. So thank you all who took the time to take the survey and return that to us. This is just a breakdown of the various sectors that responded. Majority you see there are from the hospital and healthcare as well as public health sectors of the coalition. So we appreciate everyone's time and efforts in responding to the questions. This is the description of, more specific description of who was in that other category. So we have some of our home visiting agencies, advocates, health plans, school-based clinics, F2HCs, and so forth. So thank you again. This is who is represented in terms of service area. In Region 10, you see a majority of the respondents said that they serve Wayne County, but we of course have good representation of those who serve Oakland and Macomb counties as well. Next slide. Okay, so these next few questions, questions 3 through 7, really are the recommendations from the Healthy Girls, Women, and Mothers priority in the improvement plan. And so this first question about the evenings and weekends and convenient hours for family, we've got a little bit over 60% of the respondents saying that they currently are doing this, or they are planning to do this, or they're open to doing this in the future. Number of the responses you see, well, pretty much, I think to every question, there wasn't a full 34 responses to each of them. So we had people, I think, looking for things that maybe were of great priority to them, or that they were currently implementing, or that they knew that they were implementing. So we just had 24 responses to this question. Next slide. Question 4 had to do with the preventive services through public-private partnerships. So we've got a good 90% of the responses that had to do with this in favor of they're doing it or they're open to doing it in the future. And so if you are on the call and responded yes to this, I think it would be interesting to find out exactly what you're doing. So if you wouldn't mind putting that in the chat, and we can look at that later on, or sending me a note, just kind of giving a little bit more detail about that. I think our team would be very interested in finding out exactly how you are doing this particular priority or recommendation in the priority. Next slide. Same here, greater than 90% are currently doing this activity, implementing the promising practice or evidence-based interventions when partnering with your families to promote healthy lifestyles. Doing this or interested in doing it in the future. So same thing, we'd be interested to know a little bit more detail about how you're doing that. Next one, please. So this has to do with the wellness checks for blood pressure and warm handoffs to clinical providers. So about 70% either are currently doing this or they're open to doing this in the future. So that's good to find out. Okay, next. So these next set of questions, questions 7 through 11, have to do with the optimal birth spacing and intended pregnancies priority. And so this is, looking at culturally sensitive reproductive health services, making them available to community members through innovative health methods. And the example used here is telehealth, but this is not limited to telehealth. So we've got greater than 80% saying that they're currently doing this or planning to do it. So that's good to hear that we're doing things that are really trying to make things more accessible. Next. If there's other examples outside of telehealth, let us know that you're doing that in the chat, or just send me a note letting me know those examples. Question 8, about, I think similarly, 80% of the responses said that they're currently doing or they're planning it or looking to do it in the future, disseminating information through social media on the importance of reproductive life planning. Next, please. So teen pregnancy prevention programs in communities and schools, we're at greater than 75% are doing it currently, looking to do it in the future, or planning it right now. Move forward to the next one, please. Question 10. And I know that I'm going quickly, but we are on a limited time, and we'll have these slides available for you all to view after the meeting. So question 10 is related to the locations that increase the access to families. And we've only got about half of the respondents saying that they're currently doing this or that they're open to doing it. So this may be an area of opportunity for us to consider moving forward. Next, please. Question 11 about co-locating behavioral health with other services like WIC and primary care and family planning services, prenatal care and such. Greater than 70% said that they are currently doing this work, or they're in the planning phase of doing that work. So that's good news to hear that we've got some people working on this as a strategy. Next, please. Question 12. So questions 12 through 15 are related to the strategies that are part of the full-term healthy weight babies priority area in the improvement plan. And so for question 12, we've got approximately 90% of the responses saying that they're currently doing this or that they're open to doing this in the future in terms of educating women and families on the connection between tobacco use and unhealthy babies. Next one, question 13. We've got around 90% of the responses currently doing this, or they're open to doing this in the future in terms of providing that grief support. And that's good to hear, because this was one of the priority areas that we selected as a coalition to focus on. And if you recall, at the April meeting, we placed some special emphasis on grief resources. And so we're hoping that in some small way that we were able to support our organizations, or the member organizations here at SEMPQIC, in doing this better. Next. Question 14, more than 80% responded that they are currently doing this particular strategy or implementing this particular strategy related to policies and procedures to support pregnant and postpartum women, whether it is, benefits or alternative working schedules, paid time off, and so forth. So they're currently doing this, in the planning phase to do this, or planning to, or considering it for the future. Question 15. So we've got, as far as the responses for this question, assuring that pregnant women are connected to comprehensive prenatal care and home visiting. We've got greater than 90% of the responses, either they're currently doing it, looking to do it in the future, or planning it currently right now. So that's good news. Okay, next. So questions 16 through 19 are related to the infant safely sleeping priority area, those recommendations that are listed under that for the improvement plan. And so this is, creating those support for families with young infants to assure that they're having safe sleep environments for the children, or that they're not having instances that could result in a negative outcome due to things like sleep deprivation. And so we've got approximately 90%, again, high responses saying that they are currently doing this, planning to do this, or that they are considering doing this in the future. Next, please, question 17. Again, a high rate of response, 90% around that are doing these sorts of things to support breastfeeding for moms in every environment, and creating those baby-friendly environments, whether it's in the workplace, schools, business, churches, community spaces, and so forth. So that's good. Next, please. Question 18. So everyone that responded to this question said that they're either doing this currently or are in the planning phase to provide education and messaging regarding the benefits of breastfeeding and the connection to obesity reduction. So that's good. We've got a great response rate for that in the affirmative. Question 19. And likewise, similar responses here for sharing information about breast milk being the best form of nutrition for babies. So good to know that from our coalition. So this next set of questions, 20 through 23, are related to the strategies listed in the mental, emotional, and behavioral well-being priority for the improvement plan. And so for this question 20, we've got around 80% of the responses saying that they're currently doing these things, they're planning it, or open to doing them in the future, and helping to train people to recognize signs of depression, substance use disorder, the potential for suicide attempts, and so forth, and creating those closed loop referral systems. So that's good to hear that we are having an emphasis on our mental and behavioral and emotional health. Anti-bullying, we've got just around 65% of the respondents that said that they're currently doing this or open to doing this in the future. Question 22, please. I think over 80% of the responses said that they're currently doing these things, focusing on ACEs and working to develop ways to prevent and mitigate the impact. So they're doing this, they're planning to do this, or they're open to doing it in the future. Next one, please, 23. Greater than 70% responded here to this question that they're going to be, or that they're currently including access to quality mental and behavioral health services in their employees' health benefits packages. So that is good to hear there as well. So one difference between the previous environmental scan was that not only did we include all of the recommended strategies that are in the improvement plan for each of the various priorities, we added some additional questions at the end related to health equity that touch on some of these recommended strategies for health equity. And these next questions are the strategies that are listed under that health equity priority. So implementing data-driven interventions, to ensure that populations have been haven't been marginalized have access to needed resources and services. So we've got about 95% of the respondents saying that they're currently doing this, they're planning it, or they are open to doing this in the future. Next one, please. So number 25, again, very high numbers responding that they are doing these things in terms of addressing the social determinants of health, or they're in the planning phase, or they're looking to do this down the line. Next question, 26. Same thing, 90% around of the responses are looking to assess the unconscious bias. And we are glad that we are a group that is being supportive of our members in doing this work. We, of course, have some examples later on our agenda today that are going to further support all of your efforts in doing this. But we've got about 90% that are currently doing it, looking to do it in the future, or planning to do it right now. So last one, 27, looking at the data, we've got greater than about 75, so 3/4 of the responses saying that they're doing it currently, that they're planning it right now, or they're looking to do it in the future to assess and improve how these various non-traditional health institutions, so the other sectors related to health, housing, environment, education, and so forth, can utilize health and equity lenses in their policies and procedures. So these additional questions related to health equity, we've got a good majority of the responses saying that they are using health equity tools in their work, and hopefully you can let us know which tools they are. If you want to put those in the chat, we'll look at them, or just send us a note. We're glad to consider them. Next question, please. Question 29 talks about, where they are in the process, where everyone is in the process in terms of their personal growth related to health equity in their work. And so many of the respondents said that they have reached that point where they are sustaining that transformation over time and serving as a model for others. So that's very good. More than half of the responses are in that category. Next. So this is, of course, a question that's focused on describing your organization. So we went from individual to organization. Next slide, Devin. Okay, thank you. And right in the middle there, that 33% of, so about 1/3 of the responses said that their organization has initiated the transformative process in terms of structural actions to achieve equity. And so at some point, we're wanting to have more people towards that. My organization has embedded and sustained transformation over time. So we've got, a pretty good start here. We've got more of the responses towards that than that are just kind of not moving along at all. So that's good to hear that people are doing things in this space.
Can I be
Go ahead,
heard?
Vern.
Just a quick comment on the organization. It says 14% that has embedded and sustained transformation over time. Please share some of that with us on the chat. As we're working on our equity work, we're definitely looking for examples, and we are definitely looking for ways that we can transfer some of the learning and progress in organizations here in Region 10, so we all are better. And of course, we're going to be hearing, from Henry Ford, it's right after this presentation, actually. But if you are at that point and can share or willing to share, please do so, either just on the chat or follow up with us later.
Yes, thanks, Vern. I think this is probably the second to last question. We did want to know, in terms of the COVID-19 pandemic, how your organization has implemented any initiatives related to equity. So we've got good majority of the group, about 75% of the responses that said yes. Going on to the next one. And then has the COVID-19 pandemic revealed any areas of emphasis that were not included in the improvement plan? And so most people said the answer was no. I think that we've spent some time discussing a number of those things on these calls and during these sessions. And so certainly if anyone maybe who didn't have the chance to respond to the survey, if you've got examples of things that maybe emerged throughout the pandemic that maybe ought to be in the next improvement plan or considered right now before there is the opportunity to create another improvement plan, certainly share that in the chat or share it with us afterwards. Is that the next? Is this the last question? That is the last question. So I know that I went through that very quickly, just wanting to make sure that we did not run out of time. You will have these slides available to review, and we are going to be considering this data when we are looking forward to doing some strategic planning. So thank you again for those who submitted their responses.
Yes, and just to thank you, Lisa, emphasize, is the survey still out and available?
The survey is still up. I have to create a new link for it, but I can do that.
Okay, we're going to leave it up for a couple more weeks because we want to get
Okay.
even a greater response. And we will be engaging in some strategic planning over the summer, and we'll be using the data to influence where we go forward. But I was pleased to see that we have made some progress in spite of, or I might say because of COVID, which certainly revealed significant inequities, in access. So thanks again. If you haven't filled out the survey, please do so so that we can have a more complete response. So moving on, we want to welcome Jay Clement and Allie Rooker from Henry Ford Health System, who's going to share with us the unconscious bias training model for providers. And Henry Ford has been a leader with this, and we're working with them on several ways that relates to equity and access. So welcome, Jay and Allie. Really looking forward to your presentation.
Thank you so much. And I apologize in advance. I'm not going to be able to join you on camera today, but Allie and I are happy to present this information on behalf of Henry Ford Health System and also on behalf of the Safer Childbirth Cities initiative. So let me just introduce myself and Allie first, and I'll be presenting the first half of these slides, and then I'll turn it over to Allie secondly. I'm Jay Clement. I know many of you already. I'm the Director of Community Health Programs and Strategies at Henry Ford Health System. And Allie works with us as the Senior Project Coordinator. And she has been really helping to lead and manage this project around unconscious bias. So I want to really lift up the leadership and the planning team that enabled us to do this work. So Dr. Monica Lee, Cheryl Larry Osmond, and Charlie Snow, who've all been a part of SEMPQIC as well, and you all are familiar with them, as well as some of our partners at the state level. So we worked with Ilan Gaffard at MPHI, and Kenyatta Jackson and Dan Thompson when Kenyatta was still with the state. And it was a part of, if you can go to the next slide, as a part of the Better Maternal Outcomes Initiative, which was also funded by Merck for Mothers through the Institute for Healthcare Improvement, we were funded a couple of years ago where IHI received the Merck for Mothers funding to work with 4 cities. They chose Detroit, Atlanta, New Orleans, and Washington, DC, to co-design community solutions to improve Black maternal mortality with our community partners and with mothers who had lived experience. So we started this work in the summer of 2019, and we just wrapped up this spring. And for the Detroit work, Henry Ford acted as the convener and the fiduciary. We convened a variety of stakeholders in maternal and child health, including community and government organizations, hospitals, and women with the lived experience. All of our sites, we stood up what we call Equity Action Labs, and we had design teams within those Equity Action Labs that worked to test solutions to maternal mortality in different focus areas, and each of the focus areas had different aims. So in Detroit, our 3 design teams were focused on the pregnancy space or prenatal space, the birth space, and the postpartum period. So if you can go to the next slide. And I should say I'm going to focus on the birth design space because that's where we led the unconscious bias work. But our other spaces in the pregnancy and prenatal space, that was led by Black Mothers Breastfeeding Association, and the focus is on community-based doulas. And the postpartum space was led by GDAC and Dr. Norman from Wayne State University around raising awareness about maternal mortality indicators and the kind of resources and toolkits, tools that people needed to be responsive in the postpartum space. But just focusing back on the birth design team. Of course, like I said, we partner with Women's Health, and by we, I mean the Office of Community Health, Equity, and Wellness at Henry Ford, and Henry Ford Hospital in Detroit's Women's Health Service team. We included members from Michigan Department of Health and Human Services and from the Michigan Public Health Institute. And our objective was to hold unconscious bias training with all of the women's health service staff at Henry Ford Hospital and the contributing ambulatory sites, and to develop tools and resources that would sustain the work beyond just the training. So we didn't want to just offer the trainings, check the box, and be done with it. We want to create sustainable systems to influence the way unconscious bias is recognized and mitigated over the long term. And like I said, we initially started in the summer of 2019 and we're supposed to go through the summer of 2020, but thanks to COVID, our grant was extended through the spring of 2021. So next slide. I want to share with you kind of the content of what we included in our training. And then Allie will go into the results of that training and talk about next steps and what we're planning within the context of Safer Childbirth Cities to spread and scale and expand and offer that training, these training opportunities to all of you and our partners throughout the city. So next slide. Oh, I'm sorry, go back one slide. We attempted to train about 350 people we wanted to reach everyone from the customer service reps all the way up to the neonatologists. And having both clinical and non-clinical members in the room together sometimes to influence the entire care experience was our kind of target when we started this off. So next slide. I'm sorry. So we assembled our interdisciplinary team to design the training. Through the Better Maternal Outcomes work, we connected with equity professionals at the state level. And we worked with people who had both a women's health background and people with non-clinical backgrounds whose expertise was in research or in curriculum design or in healthcare administration. So we tried to broaden the perspective of influence in designing the curriculum. And our team has met about once per month over the course of the past 2 years. Next slide. So we also really value the expertise of people with lived experience, which IHI refers to as the context experts. So we leverage the partnerships from across all of the design teams to do this, and working in particular with the postpartum design team. Focus groups were held with recently postpartum moms in Detroit to capture their experiences with local maternity care and to get their thoughts on what respectful care is and what it should look like. And we use those focus group findings to guide our curriculum. We use direct quotes from the mothers in the training. And we also engage mommy ambassadors from Black Mothers Breastfeeding Association when we actually launched the training to get their feedback from that context expert perspective. So a very well informed approach to putting the content together. Can you go to the next slide, please? So our actual training was rolled out over 20 sessions between November 2020 through January 2021. We did have to pivot to a virtual-based presentation using WebEx. We originally planned to be in person, but again, thanks to COVID, we went online. We requested that every participant complete 1 hour of pre-work, which included watching a video about the historical bias and discrimination in medicine. And we presented 2 case studies, and everyone was asked to complete the Harvard Implicit Associations test online. The actual training was 3 hours of live instruction. So it was a total of 4 hours that we request of our participants. Each session had a maximum of 30 participants, except for a few sessions that we did around the end of January. We were just trying to capture everyone we could. We had about 10 participants in those trainings. But our facilitators were members of our community health team, as well as Henry Ford Health System employees who had been part of the Henry Ford Health Equity Scholars Program, which did include clinicians from Women's Health Services as well as primary care. Each session had 2 facilitators, and we always did our best to combine the facilitators so that there was one who had a clinical background and one that did not have a clinical background. We also tried our best to always diversify the race and ethnicity of the 2 facilitators as we went along. And for the virtual components, we also always tried to have one person who handled the technology as we went along. Next slide, please. So just getting into the nuts and bolts of the content of that 3-hour live session. We started off by debriefing the implicit association test and doing a social perspective survey, as well as a short discussion on privilege. We covered the foundational concepts of health and healthcare disparities, social determinants of health, and then we move into defining and understanding unconscious bias and microaggressions. We discussed the levels of unconscious bias awareness and strategies we can use to mitigate it, as well as some cross-cultural communications models. We covered the basics of maternal mortality crisis for Black mothers, and then we connect this work to our mission and to our True North strategic plan. We did contract with Dr. Lauren Hamill, who we met at a GDAC event the year prior about equity from the Carmanos Cancer Institute. She was a guest speaker at that equity event focused on unconscious bias. And we were able to record a lecture from her where we showed the video during our training on her research that's focused on patient-provider communication and the impact bias plays on provider-patient relations. Then we discussed respectful care, including the research on respectful care, what respectful care looks like and how to provide it, and findings from the focus groups with Detroit mothers. And throughout the training, we visit those 2 case studies that we share in the pre-work, where we are able to identify incidents of bias, how it impacts the care provided, and then we dissect that with the participants of what we can do differently. So we've tried to make it extremely interactive with lots of points for discussion. And then we conclude by talking about the next steps on how we will continue the work, what people can anticipate seeing as changes on their work site, ways that they can kind of intervene and be more proactive in addressing unconscious bias activities on a day-to-day basis. Can you go to the next slide, please? So here are just some examples of the additional materials that we have. We provide everyone with a training manual so they're able to follow along, take notes. have references that they can go back to and get more information. They receive a pre-work packet. And then we have the kind of guide for the facilitators as a part of our training package. And we're adding to it a toolkit that Allie will describe later. Can you go to the next slide, please? So, of course, I've mentioned this a few times, due to COVID, we did encounter several challenges. We feel like it would be more meaningful and engaging if we were able to be in person. That said, we built in what we could to the virtual setting. So we used a lot of the chat features. We had specific prompts throughout the training for people to respond to different questions or share their reactions or experiences to different things. We used the poll feature on WebEx to get answers to questions and to stimulate further engagement. Again, we had case studies, and we're able to have sometimes small breakouts where we were engaging the audience and talking about the impact of bias and specific scenarios from the case studies. And we used a social perspective survey at the start of the training to kind of level set the conversation and really encourage that participation and engagement right off the bat from the beginning of the training. Can you go to the next slide, please? So by the end of January, our team had trained 348 members across our targeted population in 20 sessions. We don't have a finite number of the staff that needed to be trained. We think we are aiming for somewhere around 380, but because of constant shifts with leaves of absence or new hires or people transitioning out of the system at any given time, we do know that we trained at least 90% of the entire women's health staff. And again, that ranges from the customer service reps all the way up to the neonatologists. But we do know that we accounted for 100% of the physicians, OB-GYN residents, certified nurse midwives, and neonatologists at Henry Ford hospitals. So we captured all of those providers across all of the contributing ambulatory sites. So I am going to pause there to transition to Allie to describe the results and what's next for this training.
Thank you, Jay. Next slide, please. So I'm just going to talk a little bit about some evaluation results and what we're thinking about for next steps. And I'll try to go pretty quickly. I don't want to use more than our 20 minutes. So we used a post-retrospective survey to do an evaluation. We administered this through SurveyMonkey. And what that post-retrospective survey means is we asked people to think about their knowledge, attitudes, and beliefs about unconscious bias and respectful care and these issues that we talked about before the training and after the training, and compare where they were before and after the training. So we measured their self-reported change in their knowledge, attitudes, and beliefs around unconscious bias and respectful care. We used some modified questions from the ARIA scale as well, and we measured satisfaction with the training and got feedback on what we could improve. And about 88% of the people that completed the training also completed the evaluation, which we were really happy with. Next slide, please. So you can see that the understanding of unconscious bias increased about 30% from before to after the training. And following the training, 85% of the people that took the evaluation said that they understood the definition of unconscious bias a lot, or a 4 out of 4 on the scale that we provided. Next slide, please. Awareness of how personal biases show up with patients increased 28.6%. And before the training, over 40% of people had none or just a little bit of awareness about these biases. And after, only about 15% said that they had none or a little awareness. Next slide. There was a 25% increase in motivation to reduce unconscious bias with patients. And after the training, over 80% of the respondents said that they would rate their motivation to decrease their unconscious bias at a 4 out of 4. And 70% of participants after the training rated their confidence to reduce their unconscious bias at a 4 out of 4 as well. And here is how people were satisfied the training. We were pretty pleased with how satisfied the participants were, especially given all of the limitations that COVID presented with virtual format through WebEx. So 90.51% of the participants were somewhat satisfied, satisfied, or very satisfied. And only 8 people that responded to the evaluation said that they were dissatisfied in some way. And here I just picked out a few quotes of the feedback that we got about the training. One said that they really enjoyed the discussion and all the topics, and they plan to be a better nurse and advocate for all of their patients, and they want to be a bias buster. We also heard that some people thought that the training could use more personal experiences, bringing others to speak about their personal experiences and the way that they've been impacted by biases, and this could maybe have more of an impact if we brought in those perspectives. Next slide, please. We also heard that some people would like the training to be more inclusive of different types of race, ethnicities, cultures that they service and all the patients that they see. Because of the funding for this training was focused on Black maternal health. Our training obviously focused on Black maternal health and unconscious bias and how it impacts Black women. But we did hear from a lot of people that they would be interested in expanding on that and, you know, hearing about how it impacts all types of patients. Some people also said that the training was a safe place to share and felt inclusive. And we did hear from some people that they would prefer an in-person platform because it would be a little bit more engaging. And we did hear from many people that they would prefer to have ongoing trainings and have this be an annual or a quarterly thing. And here are just some recurring themes. These comments came from at least a few people in the comments. A lot of people, like I mentioned, thought that an in-person training might be better for learning and discussion and engagement. Some people said that they would prefer a shorter training spread over more sessions or more days instead of 1 3-hour session. And some people, again, said focus on more groups of people, groups of race, ethnicities, and cultures. Some people thought that recurring training should be built into their workflow. Some people thought that we played too many videos during the training and maybe move them to the pre-work so the training is more discussion and engagement with the other people in the session. Some people commented that they wish there was a little more engagement. I think given the constraints with COVID and virtual format, we did have a really good amount of engagement in the virtual format, but some people were making remarks that they wish some people were more engaged and, you know, had their cameras on and participated a little bit more. And we had a lot of positive reaction to the case studies that we discussed, and a lot of people desired to have more case studies and more discussion like that in the training. So next steps, we are thinking about replication and scale of this work, because in the Safer Childbirth Cities grant that Detroit has just gotten, that MPHI is leading, one of the aims of the work is to structurally address unconscious bias by scaling and spreading these training efforts, which Henry Ford is taking the lead on. Next step. So our goal, like I said, is to replicate our training in not only more Henry Ford departments, but also using a train the trainer model to spread and scale this unconscious bias and respectful care training to more hospitals, health systems, and other organizations. And we hope to provide the curriculum that can be tailored to different organizations and health systems to spread this work to other people. Next slide, please. So here's a breakdown of kind of what an organization outside Henry Ford will need and what we can provide in this work to replicate and scale. Your organization will need an executive champion, someone that can really foster the leadership buy-in at your organization for this work and ensure that you have the resources and the manpower and the will to take on a training effort like this. This person can be a trainer, facilitator, or they can be a separate person from the trainers at your organization. And you will need at least 2 trainers that can, do the facilitating of the sessions. They should be someone ideally with some equity background, unconscious bias background, and experience in this work. And if you'll be conducting any trainings virtually, we recommend that you have a dedicated third person during any of the sessions, manning all of the tech with the Zoom or the WebEx, because it gets really hectic trying to be a facilitator and the tech person at the same time. And then what we will provide, we are going to develop a toolkit that we can provide for this replication and scale, which will contain the curriculum that can be tailored to your organization, and also all the materials that will be needed for this train the trainer model, including a facilitator guide with all of the notes that you'll need during the facilitation and tips for actually facilitating the training. We also have the training manual and all of the pre-work materials, all of the links and the case studies and the debriefing questions for the implicit associations test. And then we will also be developing some recommended policy, protocol, systems changes, and actions that can be taken to reduce unconscious bias and improve respectful care and actually sustain this work in many different ways outside of the training. Next slide, please. So who should be a trainer ideally? Like I mentioned, they should have some background in equity work or unconscious bias work, and they should have skill in public speaking and facilitating groups. Ideally, for our trainings, we made sure that we always had at least one trainer who had a clinical background, and always tried to have one trainer that did not have a clinical background, that was from more of the community health side of things. And we found that those two perspectives really complemented each other, and the participants really valued having that community health perspective in the training along with the clinical experience. And then we also tried to make sure that there was always diversity between the two trainers. So amongst our training team for the work at Henry Ford, we had both white and Black facilitators. And so we tried to make sure that during each session, there was always one white facilitator and one Black facilitator, or at least, at the very least, not two white facilitators training in one session. And these trainers should also be able to be kind of ambassadors between your team and your organization and our team at Henry Ford, to make sure that everything's going smoothly, make sure that the recommendations are being implemented, and to share data and updates and work with our team throughout the period of this grant and this work. And that is all the information I have to share. I have my contact information here. Please feel free to reach out to me if you need any more questions answered or anything. And we also wanted to acknowledge all the people that Jay mentioned at the beginning, the Black Mothers Breastfeeding Association and the Mommy Ambassadors that helped us test our training, Dr. Lauren Hamill at Carmanos, all the people we worked with at the state, Alon from Michigan Public Health Institute, and Dr. Norman from Wayne State for all of your help with the focus groups and using your great research to inform our training. And thank you for letting us share.
Miss Anthony, you are on mute. We can't hear
Yeah,
you.
you're muted.
And this is fantastic work, Jay and Allie. Thank you so much.
Am I unmuted now?
Yep.
Yes, thank you. I was saying I can't see the screen. I lost the screen. But at any rate, again, go ahead, Alethea, make your comment and I'll comment afterwards.
I was just saying this is fantastic work, and really in line with the vision and that we had when we began our work in SEMPQIC in terms of spreading the will to include equity training and capacity building within organizations. One of the main reasons we really are so pleased that you were able to share what you've been doing is that we hope other health systems may be interested in having the curriculum in their location. I'm not going to put anyone on the spot and ask if you are, but certainly think about it. If it's in line with the work that's going on in your organization right now, and you need this step to help take you to that next level, get in touch with Jay or Allie, because this is exactly where we want to see our region move towards in order to have a more equitable perinatal system of care.
Thank you. There were some very good questions in the chat. And one thing that I want to point out is that one essential that I saw was leadership from the top. That really stood out. And either Allie or if you could, what do you think were the key ingredients that helped make this? And I know it's not over because it's a continuing process, and you've made that point. It's not like a one and done. But in addition to leadership from the top and strong support, what couple other items should be in the menu in order to make this work? Either one of you.
Yeah, thanks for that, Alethea and Vern. So I do want to say that we would love to offer this training to SEMPQIC. We know it would take a whole different meeting time set up at some point, but we want to have as much exposure as we can and we're still developing the train the trainer model. And as soon as that's ready, we'll announce it so that people can sign up and have it at their own organization. But now will be a great time to start planting those seeds of what does it take. It took the will of senior leaders being bold enough to step into this space.
Mm-hmm.
I think we are fortunate to be working as a part of an organization that already values diversity, equity, inclusion, and justice, and already had a good kind of baseline for how to approach this work. Like a lot of the clinicians who are involved as trainers have been a part of our Health Equity Ambassadors program, including Cheryl Larry Osmond, who might be on the call right now. So Cheryl, I welcome you to jump in with anything I'm missing. But we did have to do some smaller steps along the way. So we spent a lot of time organizing our thoughts and, formulating what the objectives will be. And then we went to the chair of the Women's Health Department and the chief neonatologist and the chief nursing officer and all of these people whose buy-in and permission we would need, our group practice director for women's health, and had at least an hour-long discussion. It may have been 2 hours, and worked out, different concerns they had, what they wanted to see in it. When we first did the training, we first invited the leaders in women's health to go through the training so that they could get a feel for it, and so they would be able to encourage the people that reported them to participate. So it really is an iterative process, and we are extremely grateful to Dr. Lee and to Dr. Wisdom for championing the work and not letting anyone off the hook, and figuring out the ways that we could bend and conform and get people on board with it.
Well, excellent. On behalf of SEMPQIC, we're looking forward to talking with you about how we could transfer this into a system through SEMPQIC so that many others could take advantage, because the groundwork, you've done so much in terms of the groundwork. Everybody doesn't have to repeat that. So we'll be talking about how to make that happen. So thank you. Cheryl, I see you're here. Did you have any comments?
Yes, can you hear me okay?
Yes.
I would like, this has been a great program, and I would, since the program, certainly we are continuing to grow and learn and spread the information as well. However, it was very powerful for the staff. Since that time, we are now starting a grassroots DEI task force for labor and delivery and postpartum in the maternal child team. So we have a combination of nurses and providers and OB and NICU and anesthesia that are continuing the efforts toward equity and increasing our knowledge base in some level or another. So it's certainly not the end, it's a continuation of learning and growth and being more of a community within our community of OB.
Wonderful, wonderful. Well, when we give you the updates, which is going to be after our breakout session, you'll be hearing from Alethea Carr talking about the Detroit Health Equity Network, and Karen Schrock talking about Merck for Mothers, and the healthier cities, and how all what you've just now heard can really be a part of some of this very, very significant ongoing work through SEMPQIC and through you all. And I see Dr. Daly from Wayne State mentioned some of the work that was going on there. So we're going to have to stop the discussion here, but let me assure you, this is the discussion. And there will be a lot more as we work through the processes, especially looking at where we're heading next year. So we're going to spend about 20 minutes, not 30 minutes.
Vern, can I make a quick comment?
Yes, sure. Alethea, yes.
Yes, just in, I know we have to wrap up, but I would suggest that Jay Valley note in the chat box how you did your case study collections. So again, so others, as you think about, you know, how this might be possible in your institution, they have a little bit more information to work with, because those case study, I would imagine the case studies are key to the effectiveness of the training. It gives you a chance to look at what you're doing on the job. So I'll stop there. Thanks.
Okay, thanks, Alethea. And thank you, Jay and Alec. Appreciate it very much. And we'll be talking a lot more about this. Okay, passing it on to Dr. Taylor, Iris, to explain what we'll be doing in our breakout sessions for the next 20 minutes.
What has become critical as we look at our work in reducing infant and maternal mortality, equity and disparities that exist in the delivery of care systems, is that we have been together for about 5 years. And as this work continues, we see that there is much in this work to do. And so what we would like to do is to begin to strategically plan the direction of SEMPQIC, how to better engage with you, how to better engage in the community, and more importantly, how to better address the gaps related to infant and maternal mortality in our region. So to that extent, we're going to engage in a strategic planning session over the summer. And that session would not be complete or be credible without the input from SEMPQIC itself and the members that are represented on today. So what we would quickly like to do is to go into 4 breakout groups, for which each breakout group has a question. And what we would like you to do is just to give us answers to that we could use this data as part of the process when we do strategic planning, seeing that our planning session cannot include all 100 of us as the membership in its entirety. So the 4 questions are listed here, but each facilitator of your group will have the question of your group. And for that 20 minutes, we would like to discuss. We already have recorders assigned to each group. So as Devin breaks us out, we can go right into the discussion of your group, and she'll let us know when the 20 minutes is out, and we will collect that information. We won't have a report out today, but whether that information would become valuable as we proceed with our strategic planning process. So Devin will now begin to break us out in our groups.
You all should automatically move over, at least most of you. Some might need to be assigned, so 3. There we go. Gwen. Let me make sure I can move you. Here we go.
partnerships.
Okay, welcome back, everybody.
Okay, we're back.
Vern, you're on mute. Still on mute. There we
Okay.
go.
All right, we're back. What I said that you didn't hear was, we're back. Lots of good discussion.
Ready.
Thank you so much. This is information that we'll be using over the summer as we forge ahead with planning a future for SEMPQIC. If there's any of you that are particularly interested in working with us on our strategic plan, just drop a note in chat or send us an email, because we will be putting together ways that we could hear more directly from some of you specifically. So if you have an interest in being directly involved in strategic planning for SEMPQIC over the summer, please let us know. There's a lot going on. We've learned a lot from COVID, and the problems are huge, but the opportunities are even greater as we look towards the future. So thank you for that. Now, I think we're pretty close on time, not quite, but let's have an update on some of the things that's been going on, that is going on within SEMPQIC, where we're making progress. And this is probably gonna go pretty fast, but we definitely wanted you to hear where we are with some of our major efforts. A lot of work going on between our meetings, starting with Alethea Carr, who's gonna bring us up to date on the Detroit Health Equity Network.
Thanks, Vern. Go to the next slide, Devin. This is our Kellogg supported initiative, and we've convened our Collective Impact Advisory Committee several times already. They've helped to develop a criteria for selecting the contents of the resource that will be on our website. We've also identified an online tool that our committee members will be using to rank, if you will, the materials that we plan to include in the resource. We have several suggestions that have come out of the committee for how to later share the use of the resources within our community. Various ways, blog or having webcasts or podcasts. We've also identified the back-end website elements that will need to be a part of the Detroit Health Equity Network to make sure we have a robust evaluation of the project. We've developed the first version of the Health Equity Dashboard, and we're working now to finalize that, looking at the look and feel of the final product so that it'll be inviting and easy to use by any that visit our website. And we're in the process of engaging a vendor to develop the Health Equity Network website as well as our SEMPQIC website. We expect the official website launch to happen in October, but we plan to have some testing a couple of months prior to that to make sure it delivers on what we're expecting it to do. So that's a quick version. We'll move on to MIHEIP.
I'm going to
Iris, yes.
I'm going to defer and go to Merck, and then to Dana, and then we'll see how much time you have left at the end.
Okay, because we did do a MIHEIP report at our last meeting. Hi, Karen Schrock.
Hi, everybody. You've heard from one of our major partners with Merck, Henry Ford Health System, and let me just back up and say that the city was awarded a contract from Merck. It was awarded to SEMPQIC, and SEMPQIC at the time used GDAC as a fiduciary, and with the transition that's occurred, we are now working with MPHI. So SEMPQIC was the awardee, and as such has been working to make sure that we get this off the ground. The grant began in February. You'll hear it referred to in a number of ways. Merck for Mothers, it's part of Merck's Safer Childbirth Cities initiative. And the idea of this particular grant is to focus on reducing Black maternal mortality in the city of Detroit. Without getting into the details of the disparities, just as we see in most health indicators, you also see disparities with respect to maternal mortality with Black women. So it's 4 major goals in this project. Again, the first you heard today from Henry Ford Health System, and that's around implicit bias training. And so they are off and running on that piece. The second part, you heard a reference to Black Mothers Breastfeeding Association, and they are taking responsibility along with Focus Hope in making sure that we as a community have a good number of doulas. So many of you have become familiar with the use of doulas and the positive impact that they make in communities. And the idea here is to both recruit and train and ultimately get them certified so that in the city of Detroit, we will have a full range of offerings related to support for women during and after their pregnancy. So Black Mothers Breastfeeding is taking responsibility for that. And that is a strategy that will also address Black maternal mortality. The third component is looking at something that's been discussed, whether it's around implicit bias or doulas. It's raising the voices of Black women so that they are acknowledged. We all read constantly about how Black women's voices are dismissed, either by providers or systems. And the Detroit Health Department is taking the lead on this effort through Sister Friends. And I know that they are also on this call. And the idea there is to recruit storytellers. So the idea is that we will make sure that women are able to tell their own stories and that they are equipped as storytellers throughout this community to let other women know what they can do to communicate effectively with providers, as well as making sure that they help women feel more empowered to do that. So again, that's part of the Detroit Health Department. The Detroit Health Department is also taking on the responsibility around maternal mortality surveillance systems. So just as we look at what happens when children die under age 1, we look at what happens when women die within a year after childbirth. So the city of Detroit has an exciting opportunity because they're looking not just at what caused the deaths of the women, but they're going to look also at a cohort of similarly organized, similarly categorized women and see why do some women with the exact same characteristics somehow survive and even thrive when others die. And so that's the vitality component. So you will hear a discussion of the maternal mortality and vitality review team. And they are assembling a group to look at that very issue. So why do some women with the same characteristics somehow make it and do well and others don't? So that's a very exciting component. So all of that together, looking at what's going on with women who die and how some like them make it, looking at raising the voices of women, looking at what's going on in the health systems, as you heard from Henry Ford, and making a fuller spectrum of providers available through Black Mothers Breastfeeding in terms of doulas. So that's like the quick version of what we're doing in this project. We're fortunate to have funding for 3 years. And during that 3-year period, we are going to get our community on this right path in terms of reducing Black maternal mortality.
Thank you, Karen. Now, Dana Harvey from our consultant for communications. Do you want to give us a quick update on the video toxic that we've been sharing around the community?
Yeah, absolutely. Good afternoon, everybody. Again, my name is Dana Harvey. I am the newest member to the SEMPQIC team, serving as a communications lead for the organization, focusing a large part on internal and external communications for the Merck and the Detroit Health Equity Network projects, the two that Karen and Alethea just spoke about. Did want to share information on the toxic film that SEMPQIC has been using as a tool over the past year or so. I believe a number of your coalition members have seen this, but for those who have not, it's a short film called Toxic, A Black Woman's Story. It explores Black maternal mortality and health disparities among all Black women through the eyes of a main character, and you see how that has impacted her health and well-being during her pregnancy. This film was created by 2 Cleveland-based groups that wanted to provide an educational tool to bring awareness to the racial disparities in infant mortality nationally. And so SEMPQIC has incorporated this as a tool for their efforts. Most recently, it has been shown at a SEMPQIC meeting, as I mentioned before. I believe at that time, there were about 31 community organizers. There was also a special screening that was held a few months ago in May. Well, that was last month. We had about 175 attendees for that virtual viewing, and there was a panel discussion following the event. There was a showing for the Center of Health Research and Technology on April 30th, and Oakland County Health Department and Wayne State University Nursing School also utilized the screening back in November of last year with about 18 total nursing groups. We have a number of requests that are out so far. Dr. Mariana for showing with some physician groups. Henry Ford Health System, I believe, has requested as well. Blue Cross Blue Shield of Michigan, IPH, and International Women's Forum. Those have been requested, and we do have a few that already are confirmed for showing. One of which is Wayne State Medical School for the Trailblazers medical students. That was requested by Dr. Hassan. That'll be shown in July. Also, Andrell, through her community engagement efforts, is working with a Zeta Phi Beta sorority. They'll be showing that soon. And then Vern and Robina, who was a doula that sat on our panel before, will be interviewed on a podcast next month, Power Up Women podcast. So our invitation to you is, if you are a part of any organization that would like to show this film, healthcare providers, social service providers, educators, advocates, we would love to provide this as a tool for you and your organization. We can provide you access to the film, background information for engagement, question and answers. And if you have any needs for assistance and speakers or panelists, we can assist you with that as well. You can reach out to me or to Devin. I'll put my email in the chat, but we'll make sure that you have that information. So please just know that this is a tool that you can use for your organization as well.
Okay, thank you, Dana. Again, that was one of our goals. It's excellent learning tool, and many of you know that because you've seen it. So as we wrap up here, Amy Zagman is with us. She has put some information in the chat regarding advocacy issues that's going on in Lansing. And we have a few minutes. So Amy, if you would kind of tell us what's going on real quick.
Sure. Hi, everyone. I did share in the chat just a real brief explanation. It's a very fluid situation right now in Lansing with regard to the state budget for the fiscal year that will start October 1st. The budget would normally be wrapping up right around now, but there's been an increase in proposed revenues or projected revenues, which is a good thing, but it does cause people to sort of reevaluate their position on things. So the House and the Senate have both advanced their versions of the various state budgets, and that comes into and is positioned next to the governor's proposals, which have been around since February, and now negotiations start based off those new numbers. So based off the state's revenues and also all of the federal pandemic relief funding that has come into the state. And normally we would be seeing the budget wrap up. Like I said, in fact, there's a July 1 deadline, so to speak, but the conversation in Lansing today and tomorrow is around potentially pushing that deadline out to the more sort of drop dead date, for lack of a better term, of sometime in September, when the budget really has to be done because of the October 1 start date. So I don't know what to tell folks other than this is probably going to drag on through the summer. And so I would encourage all of you, whatever way that you normally get updates on what's going on in Lansing and look to engage, just stay tuned. Right now, because of the increased revenue, there is not a lot of cuts being discussed, which is a great thing, right? We're not operating from a defensive posture. We're operating from a position of strength. And so there's only a couple proposals that have us concerned. In the House version, they don't have the funding in to continue the Medicaid postpartum extension to 12 months. And we obviously want to see that funding continue while the state gets the necessary federal agreements in place so that we will have the postpartum extension when the public health emergency expires. So we obviously want to do advocacy around the postpartum extension. And also there was a House proposal to replace Title V and Title X, which together are $28 million of essential funding for our interests around maternal and child health, to replace that with state general fund dollars. And while that might be possible right now with all of the funding that I just talked about, long-term, that's not a good choice for the state, or I would argue that's not a good choice for the state, that we want to be part of those systems and that we want that federal funding. So we've put out some action alerts from the council. I'm sure you're getting potentially from other organizations, but please, please, if you are asked to advocate, do it in whatever way you can. It's important for legislators to hear from you throughout the summer. They'll be home in their districts, and it's important for them to hear about how important these things are to the folks that you serve.
Okay, thank you, Amy. And if you would put your contact information in the chat. So if you have any questions, you can communicate directly with Amy. But we do include advocacy as a part of our major area of responsibility. And we continue to be concerned about the Medicaid expansion, because that's extremely, extremely important. And we all know that. Again, preaching to the choir. The only other announcement that we have is the Maternal Infant Health Summit. And I think most of you already know that, but the reminder is scheduled for the 28th and 29th. And I'm hearing that we have upwards of 600 people registered already. But registration closed yesterday, unfortunately. Dawn, is there any way that people can still go, or we just want to say, I look forward to seeing you all there, those of you that have registered. The only other thing I would mention very briefly is that the data, Southeast Michigan Region 10 Data Summit was last week, and we got new information for 2019, and we're still looking very closely at that, trying to peel off more of the onion skin to get a better understanding of what we did good and where we're headed for the future. So with that, I think it's 3 o'clock, and I want to thank you all for coming. And again, you will get a copy of the slides, and we'll be continuing to look at the chat to make sure that all of your questions are answered. So enjoy the rest of this. Oh, your evaluation is coming out right now. So please, what did you say, Devin?
The link for it is in the chat.
The link for the evaluation is in the chat. Please complete the evaluation. We always want to do better and better. So again, thanks everybody. Thank all the presenters and enjoy the rest of this beautiful day. Thank you.
Bye.
Bye.